Just to understand more clearly, so in one of your slides you were showing how actually it's the sort of the additional adipose tissue which is responsible for many of the kind of increased amounts of appetite, etc. So I suppose my question is, when people lose the weight on these adjuncts, and which so successfully, and therefore their levels of visceral fat go down, their levels of body fat go down, how come these hormones which are being made, which are responsible for driving behaviour, how come there isn't a shift in those?
Because of something called the metabolic set point theory, which is a theory that once you have put on a critical extra mass of fat tissue, we don't know exactly what that is yet, but in the same way that our body regulates our temperature, our body says, this is where you're going to be from now on. So if you then lose weight from that point, the minute your hormone is no longer controlled by the drugs, your body reverts to go, right, we're putting all that back on, and a little bit extra in case you try and do it again, which is why we see this yo-yo dieting pattern, which we do. People lose weight, then they gain weight and a little bit more. And so, getting fat trying to lose weight is a thing. And that's why. So it's this metabolic set point theory, or the defended fat mass theory.
And is there any research looking at resetting that?
Yes, masses. But no one's managed to do that yet. We know that metabolic bariatric surgery is probably the one thing that does reset it, which is why it's so successful. And although people do regain some weight, very few people ever get back to the weight that they were. And when I say that, I'm talking about malabsorptive procedures. So I'm talking about a gastric sleeve, bypass, or a mini bypass, or a duodenal switch. I'm not talking about balloons or bands. They're completely separate. Will we see a resetting of the set point after a certain amount of time on these medications? I would be very interested to see. We'll see. Has anyone, what we're looking at, I said about those sort of 5 to 7% of people who keep the weight off, people are looking to see whether they have something different, or were they never predisposed to getting obesity? Who knows? They just happen to for various reasons. So that's going to be the next big thing, I think, because it's going to be fascinating. Yeah. I've stunned everyone into silence.
Well, I have a question. We've got one on there. So whilst I'm coming across, what sort of side effects or adverse complications should we be looking out for people on these medications like Wegovy and stuff? Because if they're prescribed elsewhere. So. Yeah.
Some people are getting quite profound delayed gastric emptying, almost into a gastroparesis type of thing. That made the headlines. It's not that common, but vomiting, nausea is the main one. Diarrhea for some people, constipation for other people, just because everyone's different. The serious things are pancreatitis. Although, again, we don't see pancreatitis in a huge number of people on it for diabetes. So, but we have to think about it. Medullary thyroid cancer is the other one, but it's a very rare kind of cancer anyway. So they're not sure if statistically it's significant. But people who've had thyroid disorders or thyroid cancer, if you've had a thyroid disorder, some people won't prescribe it, others will. If you've had thyroid cancer, no one will prescribe you that medication. So that's the main one.
Sorry to ask you about, I know everyone's very excited about the obesity things, and that's amazing, it's all new to me, but I want to ask you about the HRT.
No, that's good.
Get us back. Okay, so you were talking about scanning in people on high dose estrogen, and generally with scanning, also for breakthrough bleeding, I know you didn't cover that, but we're supposed to tell them to stop HRT before they have their scan, and no one wants to do that, obviously, because it's horrible. So do you still think, is the scan enough with a small endometrial thickness for you to feel reassured that there's nothing else going on? They don't need a biopsy?
I don't tell people to stop their HRT. I don't really understand what the difference would be. We have a gynecologist in the room who may be able to tell me. but I don't tell people to stop. If you've got a good ultrasonographer, they can look at the endometrium. They can tell if the endometrium looks normal, if it looks abnormal, if there's areas of hyperplasia or abnormal blood supply or blood flow, if there's polyps. And with the breakthrough bleeding, people always say, when should you worry about that on HRT? For me, it's if it's quite dramatic and it's after a certain amount of time. So if it's for the first few months on HRT, no biggie, that's something that might happen. If they've been bleed-free and suddenly they start bleeding, or they start bleeding very heavily, you need to see them, you need to look at their cervix, and then get an ultrasound scan. But I don't stop their HRT. But I will write on HRT on the form so that the ultrasonographer knows, and the person interpreting the scan knows. That's all right.
I agree with you.
Oh,
I wanted to ask you a question.
yes.
How quickly can you lose weight on these drugs? I'm just thinking about, let's say somebody needed surgery.
Oh, we should be
But they
giving
were
it to
too-
everybody. You know, quickly
Yeah.
is the answer.
Yeah.
So people, there's weird BMI cut-offs that are completely random and just stigmatising unnecessary stuff. And I think that rather than say to someone, well, come back when you can't move with your knee arthritis, but, you know, I think we should be saying, we think it would be safer if your BMI is lower. Evidence is a bit crap, but it might be for some things. Instead of just sending them away to try harder, we should be prescribing them the meds. Yeah. So you can lose a significant amount of weight in 3 months. Yeah.
Yeah, and I think I've got a point as well. I'm just going to give it to Will, because I think everyone should be having these sort of weight loss medications through a specialist or a GP, and that's privately. But I just talk about the supply maybe as well, because that's a big thing.
Yes, supply on these is still difficult, but we can get it. And it's very much, we lead from you as the clinicians, does this patient want it? As a pharmacy, we're not an online pharmacy, so patients cannot come directly to us and just ask for it. And that's very core to us. We are clinician-led, and the supply of this is available, though it is still difficult.
Oh, yeah.
So we have lots of patients coming and asking us about these drugs. Where can we direct them safely? So do you know any specialists who...
So at the moment, you can refer them to a Tier 3 weight loss service if you have one locally. That is the only place they will get it on the NHS, and at the moment they kind of won't. If they have the cash and they want to do it privately, there are a few online services. Boots do it. There's one called My BMI. There's a few different ones where you speak to a clinician.
Okay.
You have a chat with them. Some of them make you send pictures in your pants to prove that you're that. And I think that this has to be done carefully. These are clever drugs, but they are powerful drugs that change a lot about you. I mean, they're thinking of using them for alcohol addiction and gambling addiction. They change a lot about you, and I firmly believe people should have access to them. I think they should have access to them via clinicians who know what they're doing. But at the moment, it's a wild west out there at the moment.
And I think actually that's something that my health specialist will look at as well. We'll get recommendations from doctors for weight loss services, which are clinician-led, and that people get access to them as well. So look out for a new category on the website, I think, as well. Fine. Any other questions? I think we'll maybe move to Q&A. Oh, Van, you have one.
Just wondering if anyone's looked at the cost effectiveness of bariatric surgery versus the injections used for weight loss in the private sector, because obviously it's only licensed for 2 years. It may increase your your weight set point or metabolic rate, and we just do not know the side effects long term. So it could be. So I just wondered if anybody's looked at that, and why would we not just refer them straight to a bariatric surgeon for surgery?
So I think that
I'll just talk loudly. I think that we know that metabolic bariatric surgery is incredibly cost efficient. It pays for itself very quickly within about 3 years. If you're going to do a head-to-head with the weight loss drugs, at the moment it's entirely skewed by supply and demand, because the cost is high because there's only one drug out. Liraglutide was there, but it didn't really work as well. So once we've got tirzepatide out, once we've got etatrutide out, then I think we're going to look. The thing to remember is that the surgery is big. Not everyone will want surgery, and so these drugs will be an adjunct and for people who don't want surgery. And it will be the same potentially as treating hypertension, treating diabetes. In fact, you're going to be treating the cause of their hypertension and their diabetes, type 2, and so it will be incredibly cost effective to treat the thing that's causing the problem, not the myriad of other problems. So it should be really cost effective. Thank you.
Brilliant, brilliant. I think, thank you very much, Stephanie. Okay. Another one, so one about the Zoe app. So the Zoe app is about the same price as Wegovy privately, and people use this for weight loss too. I have huge skepticism about the use of CGMs in non-diabetics, and I wondered what you thought. So maybe Stephanie, Rohini, so Stephanie first, what do you want to say?
I share your feelings about the Zoe app. I used a CGM after I'd had my surgery, actually, just to see if there were things that would give me dumping syndrome. And that felt like a good use, but it didn't tell me anything dramatic. You know, it tells you to eat good food. I think that if you have severe obesity or significant obesity and you're going to spend your money on something that you want to work quickly, then probably the weight loss drugs are better. But I think it's really important that those drugs are used alongside eating well and exercising, or activity. Exercising can be a word that makes people stressed. So activity, particularly strength activity. So I don't want to be a downer on a particular brand, but I don't think that the use of CGMs is going to make a big difference to someone who wants to lose significant amounts of weight.